Hello, everyone. Welcome to the webinar where we'll be discussing today about the sniper technique in central venous occlusions. My name is Marcelo Guimarães. I'm a professor of radiology and surgery at the Medical University of South Carolina, and it's a privilege to host this webinar. I'd like to thank Bailey's Medical for the opportunity to share our experience with this technique. So in part one, we discussed about the patient evaluation in clinic, patient selection, the preoperative imaging that is important to have, the importance of reviewing the anatomy in detail, and advanced techniques that can facilitate the procedure and increase safety. And in part two today, we're going to review a little bit about the equipment, the tools necessary to perform these procedures effectively and safely, and patient positioning and room setup. So it's important to review very quickly here a little bit about what we talk in clinic with these patients and how we obtained informed consent. We always discuss about hemothorax and pneumothorax as potential complications, also cardiac tamponade and death, arteriovenous fistula, stroke, hematoma, and infection. So it's very important to have an action plan in case you cannot fix the problem by yourself. So that's why we perform this procedure in the building and in our campus where CT surgery and cardiology are available. It's important to have a team approach in case things don't go well. Even though we feel very comfortable draining hemothorax or a cardiac tamponade ourselves, it's important to have a team approach in order to potentially rescue very severe complications. In addition to that, we always order type and cross for the procedures in the pre-op, and we always have blood reserved. It's important to mention and to emphasize that the sniper technique should never be performed in OBL for obvious reasons. This can be complex, it's a complex procedure and may require full support, including ICU post-procedure. The angio suite, in terms an ideal situation would be to have an angio suite that has a COM-beam CT and image fusion capabilities. That, in our experience, has demonstrated to save time and increase the safety profile of the procedure. Also, it's important to have a high-end ultrasound equipment with a linear probe to obtain venous access in a curvilinear or a cardiac probe that is always turned on, available on the patient's chest in case we need to check for pericardium effusion and to drain immediately in case there's any pericardium tamponade. In addition to that, we need to have the power wire generator, and you should also consider having ICE or IVUS as a target. In terms of ICE or IVUS, we believe that is a potential, can be used for as a target to show where the target is. However, I don't have experience with in central venous occlusions, but I do use ICE in every single TIPS procedure for our guidance. So you could also use that to guide the power wire or any other sharp recanalization tool that you prefer. One important thing to mention is that IVUS has been used by over the years to measure the venous diameter, and we do not recommend that. And the reason is in central venous occlusion, especially in chronic ones, there is a overdilation, compensatory overdilation of the vein. And if you measure that vein with IVUS to measure the diameter of the balloon or the stent, more likely you're going to be oversizing it unnecessarily. And what we have seen over the years is that there is a compensatory reduction in diameter of this vein once you open up the central venous occlusion. So that's why we recommend to use what would you be expecting to be the diameter of that vein in that anatomy in particular. For example, brachycephalic at around 10 millimeters, SVC 10 millimeters, and not oversized based on IVUS. In terms of access, we just use a regular micropuncture kit, and then we obtain access with a 0.35 135 or 150 centimeters access wire. It can be a regular J, woolly, or straight. And then from there, we use different types of 5-French semi-curved catheters, diagnostic catheters. If we come from the arm, we prefer to use a 65 centimeters in length. If you come from the IJ approach, a 45 centimeters long. And if it comes from the femoral approach, we always have dual approach, right? Upper body and lower body access, 125 centimeters long. Remember that the femoral axis, the 125, can be used not only to obtain access to the heart from the femoral approach, but also be used during the crossing, the exchange of the power wire for a 260 stiff Amplatz wire using the body floss technique, obtaining access from the IJ to the groin, back and forth, right, through the body floss. And also that semi-curved catheter can be very useful to steer the power wire, either coming from above or coming from below. And then we introduce 7 or 8 French introducer sheaths, one in each side, again, one for the upper body axis, one for the groin axis. And the French size will depend on the stent that you want to use. That can be 7 or 8 French, depending on if you use bare metal stent or cover stent. And also, we like to use long introducer sheaths for support. They can be 45 centimeters, for example, in length if you come from the arm, or a little shorter standard length from the IJ, or longer, like a 65 centimeters if you come from the femoral approach, in order to give necessary support and weight at the tip of the RF wire and at the tip of the diagnostic catheter. Here are two good examples that when we used longer introducer sheaths, one from the arm, one from the femoral, that's very important to help us to give support crossing fibrotic tissue and to give us support. So other devices that are used, that can be used to support the crossing of the RF wire or after the RF wire already has crossed from one stump to another, is to use a 4 French straight or curved glide catheter. That can be used to support the advancement of the guide wire or to facilitate crossing, especially if you use a hydrophilic straight catheter. We use a 10 millimeter snare, a end snare from Medtronic as a target. We use a 10 millimeter snare because that's the only snare that goes through a 5 French catheter. So you can use a semi-curved 5 French catheter and give guidance to the snare. And if you use a bigger snare, like a 15 or 20 millimeters, that's going to be used only through the catheter that comes in the kit that is straight, does not give you direction to the snare. So that's why I prefer to use a 10 millimeters. Also, 10 millimeters give you a smaller target, a more objective target. I prefer to use that instead of a large snare. In terms of power wire, we typically use a 0.35 platform, 250 centimeters in length, and we can use a straight or a semi-curved version, and we'll talk more about that in a minute, which one we prefer to start with. Once we have crossed and we have the body floss, so the power wire is through and through the upper body axis and the femoral axis, then we use the 125 centimeter diagnostic catheter to advance through and through, and then we exchange the power wire for a 0.35, 260 centimeters stiff Amplatz wire. At this time, when we have the wire, stiff wire through and through, is just time to predilate. Typically, we like to predilate small, 4 millimeters, 75 centimeter shaft angioplasty balloon that can come from above or from below, doesn't matter which axis. But we only do the predilation once you make sure that you have crossed a safe path. We don't want to predilate, potentially crossing arteries, then we can create arteriovenous fistula in the mediastinum, which is not a good complication to have. So here is an example of the combination that we like to use. We prefer, and that has worked for us. That's only one way to do it. There are several ways to do it, but this has worked for us in the last 13 years doing this technique. And here is a 10 millimeter snare that is advanced through a semi-curved 5 French catheter in one side of the stump. On the other side of the stump, we have a semi-curved catheter that is guiding a straight RF wire. That's what we prefer to use, semi-curved diagnostic catheter guiding a straight RF wire, a power wire. Also, at the beginning of our experience, we also used a pigtail as a target, but today we prefer to use a snare for sure, not only because a snare can give a 3D dimension where the target is, but also you can snare out right away, which is something that the pigtail does not help with. In terms of stent selection, we highly recommend to use 10 millimeter stents in very rare situations at 12 millimeters, with the understanding that not always bigger is better. So for the SVC, for example, we recommend balloon expandable cover stents, either the V12 from Atrium or the VBX from Gore, bare metal stents in the brachiocephalic most of the time, bare metal balloon expandable like the Express from Boston Sci, and self-expandable expandable stents in case you need to have a long recanalization, but does not involve the SVC. And in subclavian especially, we like to use self-expandable stents, but not in the SVC for multiple reasons we'll discuss in a few. So in summary, for the SVC, we recommend to have a balloon expandable cover stent, brachiocephalic vein, bare metal balloon expandable stent, or you can also use a cover stent if you believe that there's a risk of rupturing. Remember that once we are recanalizing with a power wire, not necessarily we are intravascular all the time. It could be totally extravascular or intravascular outside and then back to the vessel. So because there's a risk of bleeding, I prefer to use cover stent whenever I can, with the understanding that you don't want to jail out collaterals or important or the contralateral, for example, brachiocephalic. In the subclavian vein, as I mentioned before, self-expandable stents is our preferred stent, with the understanding that we don't want to put a stent, doesn't matter if it's self-expandable, in the brachiocephalic subclavian transition, where you can have the pinch effect, metal fatigue, and potential fracture of that stent in that territory. So if the occlusion, and we need to recanalize, for example, all the way from the brachiocephalic to the subclavian, sometimes you like to put a stent in the subclavian and the brachiocephalic, leaving that transition with balloon angioplasty only, without any metal stent. But if there is a refractory stenosis or compliant stenosis, that basically there's a recoil of that stenosis after ballooning only, then we prefer to send the patient for a rib or clavicular resection, and then we stent that territory after we have the removal of the pinch of the bone. It's important to consider that this chronic venous occlusions are different than just high-grade stenosis. Most of these occlusions are chronically built by fibrotic tissue. And in that situation, that's what we have learned over the years. Using balloon expandable stent will provide you more precision in the delivery of the stent and higher radial force. If you use the latest, like the Abra stent from Medtronic, latest high pressure, high radial force, not pressure, but high radial force stents, like the Abra stent, you can be used in central venous occlusions where there's a lot of fibrotic tissue, but we have to be careful not to have the watermelon seed effect that the stent potentially could migrate forward while you are deploying. So we have to be very careful in those situations. That's why we prefer to use balloon expandable in that territory. Here's a good example of a case in which we had a occlusion of the brachiocephalic vein. We use actually a venogram to mark where the brachiocephalic vein on the left was, and then we precisely deploy the stent in order to keep that vein open, as you can see, without blocking the inflow. Keep in mind that some of these patients are relatively young. They might need dialysis access through a catheter in the future. We need to keep access to the right atrium as much as possible. Here's another example of an SVC occlusion with a significant collateral through the ascus. The ascus is a very important collateral to keep open in the body. We want to try to avoid blocking that at all possible. And you can see here, again, we're able to deploy a cover stent flushed with the ostium of the ascus without covering it. This is the ideal situation. You don't want to jail out collateral circulation if you don't need to. In terms of crossing, now going back a little bit to the crossing of the lesion itself, there are two combinations at least available when you use a power wire, in addition to other sharper recanalization tools that you can use have been described. We prefer to use the power wire, and here's the combination that we prefer among the two options with the power wire. One is to use, the preferred one is a 0.35, 260 centimeters long straight power wire with a 5 French semi-curved catheter. That can be, for example, a Compi catheter or Tegmeyer catheter, this type of curve. and that allows us to steer the power wire. If there is a significant misalignment between the two stumps, so in the mediastinum, one is more anterior, the other one is more posterior, so there's a misalignment there, and you need to kind of travel into a curvy trajectory, or especially if you come from the left brachycephalic vein that sometimes has a more anterior and then posterior approach coming from the left subclavian to the SVC, then we recommend to use a curved power wire in a semi-curved diagnostic catheter. Using both semi-curved will allow you to navigate through that tortuosity and be safe as you cross. Here is the generator that I mentioned before from Baylis Medical. We typically use 1 second, 1 or 2 seconds activity within the pulse mode. Very short pulse delivery of radio frequency is exactly to try to protect the patients. One important thing to mention is we like to advance a few millimeters each time in order to be safe on the trajectory and not push a long trajectory. That's why we have the pulse being delivered in a very short period of time. In terms of access, so we always have dual access in the upper part of the body that can be typically ipsilateral to the occlusion, especially if the patient has a fistula or a graft in the arm. So it can be brachial vein or internal jugular vein in the neck, or again, we stick the fistula or the graft. And in the lower body, in the common femoral vein, in either side, or if the patient has a groin AV graft, for example, then we get access to the groin as well. That dual access is going to help us to perform simultaneous angiogram from above and from below, so we can do either multiple angiograms in AP, RAO, LAO, or to use a cone beam CT in order to define really well the stump and the anatomy. So I'd like to emphasize that we spend a lot of time planning the case ahead and reviewing the anatomy and the adjacent tissues around the occlusion to make sure we can anticipate complications. Have necessary tools handy to manage complications such as hemothorax or cardiac tamponade. Use a semi-curved catheter and a straight power wire to start if you want to start your experience using this technique. I highly recommend to use covered stents in the SVC in order to decrease the risk of cardiac tamponade and avoid jailing out collateral circulations like we mentioned before. It was a privilege to be here with you here today, and if you have any questions, please feel free to reach out to us through this email address. Thank you very much for your attention.